I am Jason Abaluck. I'm an associate professor of economics at the School of Management at Yale. My research is in health economics, public policy, industrial organization, behavioral economics. Very broadly, it's about developing tools to assess choice quality and figuring out how to reform institutions to help people make better choices.
So what's the topic that you and John Gruber are looking at in your brief?
Yeah, exactly. So it's a topic that is near and dear to our hearts after many years of research of healthcare plan choice. So I guess the upshot is that we see health insurance plans as being really complicated. And when we choose plans for ourselves, we've always found it completely befuddling. We always felt like we didn't really have the information necessary to make good choices. And it seemed like it would be impossible for other people to make good choices. And so we started writing a series of papers about how indeed it seems like people don't make good choices. And that's true in a couple of different senses. They don't make good choices in the sense that there's other plans they could choose that seem like they would provide similar quality benefits at much lower cost. We can also point to specific inconsistencies in their choices, specific types of errors that they appear to make. So for example, they seem to overweight premiums relative to out-of-pocket costs when they choose insurance plans. So premiums are this really visible thing where you see the insurance plans, you can immediately see what premiums you pay. Out-of-pocket costs are this kind of complicated object where you have to say, okay, what medical claims do I expect in the coming year? What is the deductible and the co-pays and the co-insurance? Now I have to do a calculation to figure out, in light of all of this, what are my out-of-pocket costs likely to be? And so somewhat predictably, people are pretty sensitive to premiums when they choose plans, but they're happy to choose plans that have lower premiums, but higher out-of-pocket costs to the degree where they actually end up paying more because presumably they're not aware of the out-of-pocket cost differences. We also see that when it comes to specific plan characteristics, so like co-pays, co-insurances, deductibles, these are financial attributes of plans. So we can think about the dollar value of these attributes for different people. So for example, if I choose a plan with a $250 deductible, that means that I have to pay the first $250 of my medical costs. If it turns out that I say, well, you know, one plan has a $250 deductible, another plan doesn't, people prefer the plan that doesn't, and then they say, well, I'm happy to pay $300 more in premiums to choose the plan that doesn't have a $250 deductible. These kinds of things don't make sense, and what they suggest is that people are really using heuristics. They're looking at plans and they understand a deductible is bad, a copay is bad, low premiums are good. They respond in the right direction, but they're not doing the kinds of computations that would be necessary to weigh these things against one another appropriately. So,
I mean, I guess then that leads pretty nicely into what you're recommending. So your brief is really like focused on how to help people make better choices. So what should we be doing, or what should policymakers do to get people to make better choices?
Yeah, absolutely. I think there's three solutions that we consider that we think are pretty well supported by the existing research on this topic. The first solution, which comes out of a recent paper that John and I wrote, is that we can restrict choice sets by getting rid of bad plans. So it's important to qualify this appropriately because our research doesn't show that people somehow magically can choose well when they have a small number of plans to choose from relative to a large number of plans. And I shouldn't poo-poo this idea because it sounds like it's kind of plausible that like when there's 3 plans, people can look at them carefully and make a good choice. And when there's 10 plans, they can't. That's actually not what we're finding. What we're finding is just that if you make bad plans available, people will tend to choose those plans. So you might have thought, if everyone's completely rational, that if you make a plan available that appeals to really niche consumers, only the consumers who benefit from it will choose it and everyone else will avoid it. But that's not what happens. As a result of this, what we suggest you do is that policymakers who have some say over which plans are offered in a given insurance market should restrict the plans that are available. They should say, look, if we know that a plan is bad for the vast majority of people, even if it's good for a small number of people, it's probably not a good idea for that plan to be offered on an insurance exchange, because if it is offered, many people will choose it, and they will choose it mistakenly because people have a really hard time telling which plans are good for them or not. So that is our first recommendation, is that we should eliminate plans from exchanges that are bad for most beneficiaries. Now you might say, should we go all the way? Should we just offer people one plan? At least if you're going to have a private insurance market where there's competition between private insurers, this probably is not a good idea because you need multiple plans competing with one another to push down premiums. So we're not saying you should offer just one plan. We're saying you should have several competing plans, but you should get rid of the low performing plans. Okay, so our second recommendation is decision support, and decision support specifically paired with agents that help people to choose plans that are right for them. So there have now been several experiments in health economics that test different types of decision support. Some work by John and myself, work by many others. And what these papers find is that if you just try to give people information, if you say, hey, here are plans that seem like they'll save money, people respond a little bit to this information. It's not like they ignore it entirely, but the response is very, very modest. So you'll say to people, hey, you could save $200 by switching to plan A rather than plan B. Why don't you switch? And maybe the percent of people who switch will increase from like 10 to 20%. But there's still 80% of people who could save hundreds of dollars and they don't switch. And I'm talking right now about like evidence from prescription drug insurance, where it's not as though switching, you have to like switch your physician or something like that. You basically get the same drugs, you just do it more cheaply. So why is it that people don't switch when they get this information? The reason seems to be that this is such a complex product that people are never completely convinced that they've seen all the information they're supposed to know. So if you interview them and you say like, why didn't you switch? They'll kind of be like, well, look, I was a little bit worried that maybe if I switch to that alternative plan, they're not going to cover my mail order drugs anymore. They won't send my drugs to my house. And you say to them, okay, we looked into it. Actually, they will. Do you want to switch now? They're like, well, no, I don't, because I know my current plan works okay for me. I know I could save $200, but something might go wrong that I'm just not understanding. So what's the solution to that? One solution seems to be if you pair decision support with an agent. In other words, with some human who can help reassure people that in fact, there isn't something that will be worse off about this alternative plan. It's just a plan that will do the same stuff, but save them a lot of money. And the research suggests that this combination of decision support with a human agent seems to work much better than decision support alone at inducing people to switch to lower cost options. And it seems to be cost effective even when you take into account the costs of having to pay the agent. All right, so that comes to our third recommendation.
Number three,
which is to take advantage of defaults. So what's the idea of a default? The idea is, what if a person doesn't make an active choice? What if they don't do anything? Well, you can default them into a pretty good option. Why do we think that this is important? Because the research suggests that most people, most of the time, are not paying attention to their healthcare plan choice. I know this is certainly true for me. The first year that I was at Yale, I chose a healthcare plan, and every other year they send me mailings that I don't even bother to open because I assume they're going to just put me in the same plan. The real reason is I know if I open them, I can compare the plans again, but I don't have the information necessary to choose which one is good because I can't run the complicated algorithm that we can run in our research projects to figure it out for myself. So it wouldn't even help me to pay attention, and I don't. And I think most people feel similarly. It's hard to choose a healthcare plan, so they're like, well, I did it once, I'm not gonna spend another 10 hours every year doing this. So what that means is that people mostly don't pay attention. The insurance plans know, but people mostly don't pay attention. So the insurance plans take advantage of this in their pricing by doing all kinds of things. There's something called invest then harvest. So one of the things we see in the Medicare Part D program, prescription drug insurance, is in the first year of the program, many insurers entered and they set really, really low premiums. And everyone's like, oh, this is great. The premiums are so low. And then suddenly in the next couple of years, they jacked up their premiums because what the insurers were trying to do was to say, we're going to enroll people in the first year, and then they're not going to pay attention. They're just going to stay in our plan no matter what. So then we can raise premiums dramatically. So this fact that people aren't paying attention is a problem because it reduces competition. it makes premiums high, and also it means that people aren't necessarily enrolled in the right plan because they're just sticking with the plan they chose last time, even if some other plan is better. So there's a couple things we can do about this, and I think defaults are the natural solution. Defaults basically say, look, if I don't make an active choice, instead of just assuming we're going to keep me in the same plan, we should just assign people to the plan that will save them the most money, subject to providing equal benefits. So this is an important caveat. What do we mean by equal benefits? It means different things in different contexts, but one huge caveat is in the case of typical health insurance. So not just prescription drug insurance, but now your insurance is covering your doctor and your hospital. You don't want to be defaulted into a plan where, oh, sure, it saves you $400, but now you have to switch doctors. Now you have to go to a doctor who doesn't know you well, right? So we can have, this is what we mean by smart defaults in some sense. The default is smart, not just in that it puts you in a plan that will save you money, but that it won't default you into a plan where, for example, you have to choose a different physician. We find alternative plans where they have a similar or broader network, or at least a network that incorporates all the physicians you've already seen. And then we only switch you into that plan if A, you'll save money, and B, you can keep seeing the same physician. Yeah. A further point is there's other switching costs. So it could be, even if you can keep seeing the same physician, if we default you, it's a little bit inconvenient. So what we can do with smart defaults is say, let's default the people who we know will save a lot of money. So if you're going to save $20, just leave the person in the same plan. It doesn't matter. It's not worth the risk that something goes wrong. But if there's another plan where you can save $1,500 a year, you can still see the same physicians. You still get coverage for all the things that you're likely to need and almost equally generous coverage. It's like, we should default you into that plan, and you have the option, if you want, of saying, of vetoing that. You can say, no, 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 no. I want to stay in my same plan. Fine, then stay in the same plan. But if you're not paying attention at all, we'll put you in the plan that saves $1,500 and you'll be happy. And I mean, I wish this happened to myself. I wish there was someone running an algorithm in the background that would say, hey, we're going to put you in the plan that's suitable for you.
Yeah, and I think what's so interesting is like the default, the inertia is such that like one party is going to benefit. It's either going to be the insurance company or the consumer. And what you're basically saying is let's have it structured so that it's the consumer, not the insurance company, which seems incredibly, because it's not as if you can get rid of this inertia. It's just a question of like whether you want the surplus from it going to the consumer or to a company.
That's right. I would even say a stronger thing, which is it's possible that, you know, the total size of the pie can increase as well by just better matching people to plans that are more suitable for them. So for example, certain types of people, it's really important to have more generous coverage to offer them more risk protection. For other people, it's not. But I agree that broadly, the first order thing you're talking about is we're trying to say, hey, there's a lot of insurance plans out there that are basically taking advantage of people, that are artificially differentiated. They're not really offering better benefits to most of the people who choose them, but people choose them because they can't tell the difference. And to the degree that we can reduce that artificial differentiation, we make the market more competitive, premiums get lower, people get enrolled in more suitable plans for them, and that is a better functioning market.
Perfect. Now I know, sort of calculating savings from this are sort of hard, but do you have a sort of sense? Some of this accrues to the individual, some accrues to the government, but how do you think about scaling the savings?
Yeah, exactly. So I guess the kinds of calculations we can do, there's a couple different ways of thinking about the savings. And you're right that there's a complicated question of how much accrues to the government and how much accrues to individuals that really varies a lot depending on whether we're talking about, Medicare Part D or ACA plans or Medicare Advantage that all have different institutional features that figure into that. But one thing we can do is to say, look, how much money are consumers leaving on the table by not enrolling in better plans? How much money would consumers choose each year, or how much money would consumers save each year if these kinds of policies were in place to direct them to more appropriate plans? And then the government would often save a lot of money by this reduction in premiums, part of which is subsidized by the government, et cetera. So the way that we do this calculation is we say, look, if every individual, so in Medicare Part D, for example, saved $100 per year from improved choices, which we think is an extremely conservative estimate, given the existing literature. then that would result in $4.5 billion in savings for Medicare Part D. It's $2.2 billion for Medicare Advantage, $15.8 billion in employer-sponsored plans, for a total of $22.5 billion in consumer savings per year. And that's about 1% of total Medicare spending, 1.3% of total commercial health spending. So, I mean, it's very easy to get numbers on the order of 1%. My view is if you could really implement these programs well, the potential savings are much larger, because in Medicare Part D, like, the average person we find is leaving not $100 on the table, something more like $300 or more on the table. In Medicare Advantage, it's often in the thousands of dollars that are being left on the table by not choosing more suitable plans.